All right, I think we can get started. Nice to see everyone today. We still have a lot of people logging in from all over the world joining us today. My name is Emma Greenwood. I'm the founder of the Pulsatile Tinnitus Foundation and Wooshers.com. This is our fourth international webinar, which we're pleased to provide to all patients and their medical professionals around the world that help them. Today, we're going to go over a lot of information and news and support. We do have links to our prior webinars on Wooshers.com, which is managed by the Pulsatile Tinnitus Foundation. If you are new to Pulsatile Tinnitus, and this may be the first time you're attending one of our webinars, you can get links to prior webinars on the Wooshers.com website. There are also a couple on the Pulsatile Tinnitus Foundation website, which is at pulsatiletinnitus.com. We collected a bunch of questions over the last few weeks from our community. We're going to get to as many of those as possible today. I did want to mention that our foundation website recently launched. It's again at pulsatiletinnitus.com. We're very excited about this. The foundation is a nonprofit. We depend on contributions to do all of our work. I should mention all of our panelists today are attending and sharing information at no cost. They're not collecting any fees or anything like that. We do all of this work because we care a lot about the community and want to help all of you. So we really would very much appreciate any contributions that you can make either today or at any time to the foundation, and all proceeds will of course go to helping our community. And these are our distinguished panelists today. Many of you will recognize them. They've all been on prior webinars, and Dr. Shapiro and Dr. Sismanis have some short presentations, a couple short presentations to start. We're going to start with those, and then we'll move directly into questions and discussion. I won't go through their lengthy credentials, but I will allow each of them to introduce themselves and tell you a little bit about who they are, where they practice, and their work for our community. So with that, I will turn things over to Dr. Sismanis.
Well, thank you very much, Emma, and I thank you for all you have done for people with pulsatile tinnitus. Your efforts and contributions are really very, very important, and I am very appreciative of them. I'm Aristides Sismanis from Virginia Commonwealth University, where I'm an Emeritus professor, and I still am active in the clinical practice of otology. So I will start with a presentation on the evolution of diagnosis. Pulsatile tinnitus continues to present a challenge to the clinician, a diagnostic and often management challenge as well. First of all, the origin of this symptom is a true vascular phenomenon. So when blood runs through a stenotic, a narrow blood vessel, then the blood flow becomes turbulent, and that creates the pulsatile tinnitus. The same way when the blood flow increases through a blood vessel. Now, I became interested in patients with pulsatile tinnitus back in 1981, 42 years ago, when I saw this patient, a young female with pulsatile tinnitus and frontal headaches and blurred vision. Actually, it was a neurologist that has seen the patient initially, and I was asked as a consultant to evaluate the patient. Now, the differential diagnosis back in 1981 was very limited. The number one thing you wanted to rule out was an arteriovenous fistula or malformation, something that potentially could be associated with a stroke. Glomus tumors, which are vascular tumors of the ear and the skull base, and other vascular blood vessel abnormalities of the middle ear. And many times we could not reach a diagnosis, and we used to call it venous hum or idiopathic tinnitus. All of these cases, it was required to get an angiogram. Now, this patient, my examination was actually everything was normal. I ordered the angiography. At the time, there was no MRI, and that was normal as well. So I went back to let the patient know about the normal results. And I was astonished when the patient told me that the tinnitus, the pulsatile tinnitus, has stopped following that lumbar puncture that the neurologist had done. And she was diagnosed with what was called at the time the tumor cerebri. So that was the impetus, the stimulus for me to start investigating this syndrome and the pulsatile tinnitus that was associated with it. Now, here is an article that summarizes the state of the art back in the early 80s and 70s, written by Dr. Paul Ward, who was a giant of the field of otolaryngology at the time. And what he was recommending for cases that everything was normal, you could not find any etiology, you ligate the internal jugular vein. That was very tempting because in many of these cases, when you put your finger over the jugular vein and press on it, the tinnitus stopped. So I can say right now, this is never, never, ever to be done because it has very bad complications. By 1987, I had accumulated 20 female patients that you see here, all of them of childbearing age, all of them overweight, and that they had pulsatile tinnitus and associated pseudotumor cerebri or idiopathic intracranial hypertension. Both are the same, indicate the same condition. Then 12 years later, I published on 56 of these patients, again, intracranial hypertension with pulsatile tinnitus and other symptoms that you see here. And recently, I reviewed 241 patients that were seen at our institution in a decade between the years 2013 and 2023. And I was able to find 29 different diagnoses. So you can see here the number of etiologies has increased since the time I started being interested in this entity. And I'm not saying that these are all the diagnoses, because I bet there are many more that will come up in the future. So why do we see more cases nowadays of pulsatile tinnitus? I think most of us agree that pulsatile tinnitus goes along with the number of cases of obesity that has increased recently in the last decade. We speculate by the year 2030, 50% of the American people will be obese. That means BMI more than 30. Why do obese patients have pulsatile tinnitus? Well, this is based on the work of Dr. Sugarman, Harvey Sugarman, the late Harvey Sugarman, who was a bariatric surgeon at my institution, and I had the privilege of working with him for a good number of years, and I did learn a lot of him. Simply made it is that when the pressure in the abdominal cavity, in the belly increases, that increases the pressure inside the chest because the diaphragm is elevated, and that results in increased pressure in the veins inside the head. And this results in difficulty of the CSF, of the cerebrospinal fluid, to be absorbed, and that results in elevated pressure in the head and also pulsatile tinnitus. Now, despite well-established and effective diagnostic protocols all these years that we have put together, still, if you look at the literature, undiagnosed cases of pulsatile tinnitus are up to 50%. Now, I will outline the evaluation protocol at our institution, which starts with a careful history. You want to know the characteristics of the pulsatile tinnitus. Is it whooshing? Is it swooshing? Is it fetal monitoring thumbing? It's very important to get this information from the patient. The next thing I want to do is I want to make sure that it's synchronous with the heartbeat, that it's true pulsatile. So all I do is I feel the radial pulse of the patient, and at the same time, I ask the patient every time they hear the pulsatile tinnitus to raise their finger. So in this way, I can tell that it's synchronous with the heartbeat. Are there any aggravating, alleviating conditions? Oftentimes, patients with pulsatile tinnitus, they'll tell you, I turn my head to the right and it goes away, or I turn my head to the left to the tinnitus and it gets worse. That tells me right from the clinical history that this type of tinnitus, pulsatile tinnitus, originates from a vein inside the head, is what we call venous type of pulsatile tinnitus, which is the most common type of pulsatile tinnitus. Associated symptoms like headaches, visual disturbances, all that are suggestive of idiopathic intracranial hypertension, phonophobia present in patients with migraine. Migraine is not uncommon to be associated with pulsatile tinnitus, and hearing loss, dizziness, oral fullness, all these are important symptoms to elicit from the history. How bad does this pulsatile tinnitus? Does the pulsatile tinnitus just worries the patient, or is it really disturbing? The worst type of pulsatile tinnitus I have seen is in patients with aneurysm, with arteriovenous fistulae. In those cases, it's very, very loud, and it's one of the few cases of pulsatile tinnitus that I have come across that patients have suicidal thoughts. Is there any history of migraine, of anemia? Physical examination. I start with a simple test by applying gentle pressure over the internal jugular vein on the lateral side of the neck. If the pulsatile tinnitus goes away, I know it's of venous etiology. That means it originates in one of the big veins inside the head. Otoscopy, I want to see if there's any mass lesion in the middle ear, suggestive of a vascular tumor. And then something which is very important, it's the auscultation. I want to auscultate the skull, the areas around the ear, the neck, and even the heart. Last week, I had a patient, a male patient, with aortic stenosis, which typically radiates the pulsatile tinnitus to the carotid artery and then to the ear. So in that case, the origin of the pulsatile tinnitus goes in the heart. So it's very important for your physician to perform all these parts of the examination. I take the patient in an audio booth where it's very quiet. You cannot auscultate in a regular examination room because there is too much noise. And I use an electronic stethoscope that magnifies the loudness of the pulsatile tinnitus. And then I check while I'm auscultating the effect of pressure in the neck and the pulsatile tinnitus, which can tell me again if it's of venous or arterial etiology. And here you see how I perform the auscultation. Here is a typical sound of a patient with pulsatile tinnitus. And then I think all these patients deserve a hearing test. In many cases, when the patient presses over the ipsilateral side of the neck, ipsilateral to the pulsatile tinnitus, the tinnitus goes away. And if you repeat the audiogram, it normalizes. So this is a pseudo type of hearing loss, and the audiologists, they have to be aware of it. Otherwise, they give you a report that there is some hearing loss, which is, as I said, the pseudo type of hearing loss. If it's a female, overweight, young, childbearing age, then I'll need a neurology evaluation in order to see the eye grounds to make sure they don't have any swelling of the eye grounds, what we call papilledema. In most of these patients, I will get a complete blood count because anemia is not an uncommon cause of pulsatile tinnitus. If there is any question about thyroid disease, I'll get the appropriate test for thyroid. And we come to the radiologic evaluation, which is very important. That can be either an MRI, MRV, or a CT, CTA, CTV. Is angiography indicated on everybody? The answer is no, absolutely not. There are certain indications for it, and it's mainly for patients with arterial type of pulsatile tinnitus. And this is from a recent review that I made on 241 cases with pulsatile tinnitus, most of them females, as you see here, seen at our institution between 2013 and 2023. The majority of these patients, 20%, they had idiopathic intracranial hypertension syndrome. And then many others, they had abnormalities of the dural venous sinuses. These are the big veins inside the head. And then there's another number of etiologies. Something that can lead to a stroke, an arteriovenous fistula. There were only 4 patients here. So many of these patients did not have any entity that could lead to a stroke, but still they had underlying etiologies that they needed to be taken care of. So in conclusion, the history, auscultation of the skull and neck and the cervical compression test are of utmost importance. The radiologic evaluation should be individualized according to the clinical evaluation. Angiography is indicated for selected cases only. Idiopathic intracranial hypertension syndrome, dural sinus wall abnormalities, anemia, atherosclerotic carotid artery disease, and migraine are common etiologies of pulsatile tinnitus. Young, obese females should alert the clinician for idiopathic intracranial hypertension syndrome. In such patients, evaluation for associated comorbidities is mandatory, and comorbidities are present in the majority of these patients, like hypertension, obstructive sleep apnea, gastroesophageal reflux, etc. Thank you very much for your attention.
Thank you, Dr. Sismanis. And now we'll turn over to Dr. Shapiro.
Amari, thanks so much. Thanks to all of you for attending. We've had a number of these, and you know, it's summer and everything, so good to see you. I think you know, this is, I just want to say a few words about this. Dr. Sismanis's excellent presentation really sums up a lot of what kind of the evolution of pulsatile tinnitus evaluation has been. And basically what I want to say to all of you is that we have come a long way, but you know, in medicine, progress is often slow. And it's slow because either because we don't have, we don't understand the diseases, you know, we don't have the tools, we didn't know there were genes, for example, at some point. Now we know there are genes, and it takes a while to understand how some diseases come around. Same with this, you look at Ari's presentation, decades ago, you know, his first patient he saw the year I was born, you know, it's like this. Actually, no, it was 75. So it was Ward was 75. I could walk by the time he saw the first one. So it's not, you know, a lot of times it's a recognition that something is real. And I know, to many of you, this is very, very much close to your heart. My symptoms are real. It's just a lot of it is like this, like my symptoms are real, what is it? They're just, they're saying something, I don't know, whatever, I don't know. It's not, they're making it up or something else is going on. So this is not the only disease where this has been like that. Really, like it takes time to put all this together. And like, finally, I think right now we've entered sort of like there's that curves, right? Like you see how a lot of curves are like this, something sort of like just putters along and suddenly takes off. So I think we're kind of have taken off in the past couple of years in many, and much actually of this credit goes to Emma and the foundation because, and Wooshers, actually really Wooshers.com, because really like in this disease, and we see this with some other things that we're doing now in our field. Like we see how social media, which is a double-edged sword, of course, like for better and for worse, internet, but this has been like a big force for the better. A lot of positive has come out of this stuff. And pulsatile tinnitus has been one of these. Just galvanizing, understanding, bringing people together, education, like education of physicians. As Ari said, like ligation of jugular vein, bad idea, but first recognizing the symptom and then taking it to the next step. And then it takes a while to convince people that this is like a new disease or new thing that is not new, but newly recognized. So I think by now it's been a story of like a lot of success. Challenges, there's a lot, but been a lot of success. In neurointerventional community, which is not the community of ENT, it's the community that many of you know, like endovascular neurosurgeon, interventional radiologist, interventional neurologist. These are people that deal with like catheterizations, diseases of the brain and central nervous system, dealing with blood vessels. So in that community, the awareness is like excellent by and large. I just came back from, I was part of like a committee, organizing one of the largest meeting of our society called SNIS. I'll talk a little bit about it. And there's a lot of work being done in the veins over there. So I think there's a lot of awareness. There's more will be done. There's a lot of work to be done left. ENT community, a lot of them still need to be educated. The neuro-ophthalmology community is also very varied in terms of their approach to intracranial hypertension. The big idea of this that you saw from Dr. Sismanis's presentation is that pulsatile tinnitus we knew was associated with these dural fistulas, which everybody knew about, but they're quite rare. The thing that's emerged in the past 10, 15 years is that venous causes, venous stenosis, venous hums, venous intracranial hypertension related things, like those are the main ones. And that's what Ari's been talking about. This is the main bulk of people with this disease. And it often affects younger people, more predominantly women. But there's, we see like older men with this thing too. We'll get into that a little bit. So that's been that's where a lot of the changes come in. And intracranial hypertension is not a well understood disease. And it presents in many ways, as Ari said, like a lot of it is still missed if it's not classically present. So like there has to be, we'll get into that with question and answers. If you're the one with, if there's a suspicion of that, it doesn't have to just present with headaches and blurred vision. Like there are many other ways this thing can come around and show up. And pulsatile tinnitus is one of it. So we'll get into that. So there's like some education to be done in the neuro-ophthalmology community, which are neurologists specializing in like eyes, basically like in neural pathways and how vision information is processed in the brain, not the eye itself, which is ophthalmologists. So that's another thing where we're going to be doing some work as a foundation. There's some dedicated treatments on the horizon. We are using for venous stenting, which we do, which is a treatment more and more recognized as a legitimate way to treat intracranial hypertension and standalone pulsatile tinnitus, which is often associated with subclinical intracranial hypertension. But even when pulsatile tinnitus is the only real symptom that bothers the person and their eyes are fine, everything else is seemingly okay. Stents do very well. And there are in development dedicated stents for this problem. We use, like right now, we use stents that were developed for other purposes to treat this. Basically, stents developed for carotid disease. So we use them off-label, which a lot of medical people do that for different devices all the time. So that's certainly allowed and legitimate. But having dedicated devices will hopefully help a bit. And like I said, the society, so there's a Venus group in the society now. So things are moving forward with that. The 10 tips that we developed, the 10 tips for physicians that we developed years ago is very popular. I think you as patients can bring them to the doctors. You could show them, you could refer to the foundation that this is legitimate. This is, this is real. We're translating the tips to different languages and working with some societies like other countries, non-English speaking countries, to kind of push this forward. Emma and many of patients, like maybe yourself included, the ones on this webinar, maybe you'd help contribute to basically pushing for dedicated codes, for medical codes, ICD-10. It's important for insurance coverage and all of these things. So these codes are important, getting the ICD-10 codes. Let me just skip over that because I already talked about it. So this is the future. You can never, predicting the future is bad business, no matter who you are. But the future, I think, if you look at what's going on, there's going to be a lot more, hopefully, like knowledge penetration into medical community about pulsatile tinnitus, especially the venous causes, which we hope, which we're hoping to contribute to as a foundation. That's our main goal, is education and help. Dedicated devices, increasing expertise. That's important. What I see, because there's so much interest now, there's a lot of people by now that understand the disease as much as we can understand it today, and understand who the right patients are and what are the right patient treatments for the right person. As in any time when there is like evolution, when things are new, there's uncertainties, like who are the right patients to put a venous stent into, for example. The classic patient is one with pulsatile tinnitus on one side, who can stop it by pushing on, their jugular, and who has a stenosis on an MRI or CT. That's the right person generally, but it gets more complicated. So we need to certainly develop some standards and education of people, physicians, like what are the right. There are also things, things are being explored that are not maybe necessarily the right things to do. Just like Ari said, ligation of the jugular was a bad idea because they basically closed the biggest jugular, the biggest, outflow out of one's head that they have, which is not good. The jugular is there for a reason. You need it. The same thing, like a lot of things are happening. So there's like interest in doing venous stenting, like putting a stent not in the head, but putting a stent in the neck, where sometimes there are stenoses, narrowings, like of the jugular vein, that the C1 segment, basically, where it's kind of compressed between two bones. One is called the styloid, one is called the lateral mass of the C1. It's one of the bones in the neck. There's stenting happening there. Sometimes it works well. Many times putting a stent into the neck does not work well. It leads to sometimes problems immediately, sometimes problems later, because a stent is a metal tube. It rubs against two bones. So metal starts fighting bone. Usually the bone wins and the metal breaks and other things happen to it. There's nerves nearby. So there are some cautionary things. So, our experience with cervical stenting has not been good. And there are surgical options for that. So there's a surgical way to relieve that pressure. It's a surgery. It's not a stent. It's not minimally invasive. But, sometimes you still need surgery. So we can talk about that if time allows. So anyway, I went a little over time. I'm sorry, but just want to say that I think the washers and the foundation have done, I think we can claim very legitimate credit for doing a lot of, being part of a lot of the advances that have taken place. We hope to continue to do that. And I think the future looks, in general, the future, I think, looks good. A lot remains to be done.
Thank you. Thank you so much. Well, wow, there's a lot to unpack in both of those presentations. Great presentations. We actually did receive a lot of questions about intracranial hypertension and transverse sinus stenosis. So I think I might just jump right in with some of those. What for intracranial hypertension, what about patients that are not overweight and that are experiencing some of the symptoms, not just pulsatile tinnitus, but perhaps headaches, et cetera? Well, do you see patients that have intracranial hypertension who are underweight? And do you see men come into your practice who end up with a diagnosis of intracranial hypertension? And that is one of the questions that we received in chat.
May I go first? Well, I've seen in the past 42 years, 2 males with intracranial hypertension. Now, there are some neurologists, and again, I cannot speak with the authority as a neurologist because I'm not a neurologist. But having read the literature, there are some neurologists that they don't believe that idiopathic intracranial hypertension can occur in a male. A male with intracranial hypertension probably has another reason for that, and not uncommon reason is obstructive sleep apnea. And what's happening with obstructive sleep apnea is that you have increased the CO2 that results in dilatation of the blood vessels in the head that results in intracranial hypertension. So now in the literature again, in Asian countries like in India or in China, you may have, they have patients for some reason that they are male and without being overweight. But in the United States, as I said, is very, very unusual and even questionable if it does exist as idiopathic intracranial hypertension. It can be intracranial hypertension, but not the classic IIH syndrome.
Okay, Max, I want to hear from you too, but David, I'm sorry, I skipped over you. I know you wanted to say a few words after the initial presentations. Oh, and you're on mute, I think.
I'm happy to just participate with questions and answers. I don't need to, but since you said something, I would just say I don't really have anything. Dr. Sismanis, Dr. Shapiro, the presentations are terrific, and I agree this is a field that has shown rapid growth recently. I think it's important to recognize that in general, as physicians, we like to talk about a cause of something. Someone comes to us with a symptom, we want to find the cause. And that's generally how medicine works. You assume that if there's one cause that can explain something, that's sufficient. You don't have to go looking for other causes. Here, where you're talking about hearing an abnormal sound, a sound that you shouldn't be hearing, it is quite possible that it's more often than not, or very commonly at least the case, that there could be more than one thing that's contributing to this. I was walking near the creek by our house with my wife a few weeks ago when this clearly hit me, that you walk past the creek, and if there's one area in the creek where there's one rock, it makes a little bit of sound. If there's a rock and then a log right after it, the sound is louder. And if you walked there after the rain, it's even louder. And there are many things that can go into contributing to making a sound louder and louder in your blood flow. And there are things that can occur in the ear that make you more sensitive to hearing a sound. And it's not uncommonly the case with pulsatile tinnitus that there can be more than one thing contributing. I think transverse sinus stenosis is an excellent example of this, that in some people, transverse sinus stenosis alone may be enough to cause a sound that's sufficiently loud. But in many people, it's causing a sound that's loud, but maybe not sufficiently loud, unless there's something else going on that's giving that sound greater access to the ear, such as a sigmoid sinus dehiscence or a superior semicircular canal dehiscence or something like that, that's sensitizing the ear. So although we like to always think of one cause, it's important in this specific field, I think, to always think about the possibility of multiple things all coming together and contributing to lead to the end symptom that the person is having. And if that's the case, you also have to think about, well, which is the easiest to treat, which is the safest to treat, what order should I treat them in? Maybe I should treat anemia first, or thyroid function first, and then something else, and then something else. And you have to have a systematic way of thinking about that. So that's all I would add to what had been previously said.
Great. And Max, I do want to just mention a couple things before I let you answer my question about IAH. Is you mentioned the top 10 tips file. I just wanted to let everyone know that may not know that file is available on the foundation website as well as wooshers.com. And as Dr. Shapiro mentioned, we just recently updated that. So please take that with you. We like to say, keep it in your back pocket when you go to doctor's appointments. It was written by all the doctors joining us today. So it was written by doctors, particularly for doctors, which you can tell your doctors. It's not just something that a bunch of random, uneducated people wrote and provided on the website. So that's another resource. We also have an informational sheet, also written by all the doctors from the foundation. Thank you for whomever is sharing this. The top 10 tips is there on the left, which is available for download. And then on the right, all the way to the right, there's another informational page with a guide to evaluation and treatment. Both of those, I think, are really helpful as a fellow patient. I wish these were in existence when I started experiencing pulsatile tinnitus, for all the doctor's appointments that ended up in frustration on my end because doctors blew me off and didn't know what pulsatile tinnitus was. So this is a great resource. Both of these are really great resources to know about and use. And the codes also, the codes are there at the bottom of this particular document. This was a huge win for our community. Even before the foundation, I believe, was in place. We had started a petition for specific medical codes for pulsatile tinnitus. Why? Because as many of you have experienced, many times you go to the doctor and they refer to your pulsatile tinnitus as tinnitus or tinnitus, and it's not the same. The workups are different. The outlook for treatment is different, whether you have pulsatile tinnitus or tinnitus. So it was very important to us early on to, as much as we could, distinguish pulsatile tinnitus from tinnitus. And these codes actually do that. So there have long been codes for tinnitus. Those are still around. But if you go to the doctor and your records note tinnitus codes and not pulsatile tinnitus codes, you can nudge your doctor to, maybe add these or include these or remove the, I think best would be to remove the tinnitus codes from your records altogether. And importantly, I'm not joking when I say this, and again, many of you watching have experienced this as well. If you have tinnitus in your medical records and your doctors order diagnostic tests, many times the insurance companies, because there's no known cure for tinnitus or tinnitus, will not approve the diagnostic tests for pulsatile tinnitus. They are, of course, warranted in our cases. So again, this is another reason why the codes are really important. So anyway, sorry, that was a little segue, but with that, I wanted to jump back to the IAH question. And men and underweight women, we have a large Facebook group, now over 15,000 members. There are a significant number of male community members with IAH who have been diagnosed with IAH. Also, women who are not particularly overweight. And in fact, many are underweight. So I guess that's one of the reasons why we're wondering about your opinions, all of you, for this question. So Max, I'll give you an opportunity to comment on that question.
Sure. No, I agree with what David said. Like what happens is, you know, and I think Ari said initially that there, you know, like theories about what intracranial hypertension is caused by. The word idiopathic, it's like the joke in medicine. Idiopathic means the idiots don't get it. Like the doctors are the idiots. They don't understand what the cause is. You know, idiopathic means the cause is unknown, that there is a cause, we just don't know it. You know, we don't understand it yet. And a lot of times what happens is in some diseases, the cause is multifactorial. So sometimes there's more than one reason for something to come about. Like regular hypertension, most people just have hypertension, they think because they're, you know, they're older now and their just blood pressure is going up. But there's a reason for that. You know, and some people have it for other reasons, that they have some other issue that causes hypertension. Same thing with this. So yes, the demographic is like the classic is an overweight young woman, fine. But it's not always the case. In part, it's probably because we don't really understand what causes intracranial hypertension in everybody. I think this pressure business, the abdominal pressure, diaphragm pressure, I think is true in some. I'm not sure if it's true in all people. And as David said, there is, so this venous sinus stenosis and the relationship between intracranial hypertension is also not clear. There's a chicken and egg thing. So some people believe and continue to believe that the venous sinus stenosis is what causes intracranial hypertension. Others, including myself, and I think more and more people are coming around to believe that this is a secondary phenomenon, that it's the intracranial hypertension which causes the sinuses, these veins in the head, to be narrowed. Which means, so I'll show you a couple of pictures. Just take a little bit of time because I think it's important. As a lot of people like have this question here, what to do with this. This is on a website called Neurointerventional.org, which I and some other people are running. And so there's a big section on that, on pulsatile tinnitus. You could take a look. There's a lot of images there if you're into like putting words together with pictures. And so basically, this is a picture of two different people. This is actually an elderly man on the right side, who's been suffering with pulsatile tinnitus for like over a decade. And everybody don't know why is it? No, I don't know. Hard to know why. This is a younger woman. And so this is what what David was saying. So in some people, the stenosis is extrinsic, means the high pressure of the fluid around the head causes a compression by some mechanism, narrows the veins. And you have an MRI. This is an MRI of this person. There's a cut here. You see a normal kind of like size of this, what's called the transverse sinus on the right. Usually the right side is bigger than left. And then there is a narrowing here. And then it becomes wide again. And you see like a jet of flow, actually. This is what's called a jet artifact. An MR where you could see like the actual, like the turbulent flow that Ari was mentioning. This is the turbulent flow that's hitting the bone here, right next to this person's ear, which is here. So this is like the classic, everything is in this picture. This person has classic pulsatile tinnitus, goes away with right jugular compression, okay? Now this is an elderly man, okay? He also has stenosis of this area. Now, why does he have it? Because of these little black circles that you see in here, which is different from this, right? This is like smooth, long compression. This is focal stenosis. These are arachnoid granulations. These are these normal things that we all have in our heads that have to absorb CSF and things like that. But this person has these grouped granulations that happen to be like all in one spot as opposed to scattered everywhere. And so that's why this particular man has pulsatile tinnitus. And so this is one example of the distinction between intrinsic and extrinsic stenosis that helps explain why that happens. So I think we're starting to understand, you know, why this is the case. In some cases, we don't really know that for everybody. So in some cases, we don't really understand. So we recently treated a woman. She was a little overweight by category, not obese, but overweight. Now she happens to have intrinsic stenosis, like even though you would expect demographically that maybe she would not, but she had intrinsic stenosis and that's how she presented. So, you know, it's a long explanation, but what basically is happening, as you can see, is that whenever we it's the evolution of treatment. You know, it starts with this thing. Now things are getting more complicated. We start to understand how things may be different in different people. And that's helpful. Like in the big scheme of things, for the people with this disease, there's more and more places where there's a lot of understanding of what's going on. And, you know, certainly there can be challenges like geographically or in terms of access to care. How do you get to this or that place? But there is more and more expertise, and we were educating people on that. We're hoping to push that out to, you know, more and more places.
Can I just make one comment on that? It was a great explanation, Max. Because I think it's important to see that doctors can disagree with each other too, or at least have different opinions on something. I don't disagree with anything particular that Dr. Shapiro said, except for the one point that he said that the MRI shows the whole picture there. And I don't think that MRI necessarily shows the whole picture. We could go back at it and I would look at it with him in detail. But one thing that MRI doesn't show is what's going on with the bone overlying the sigmoid sinus distal, just beyond that stenosis. And if you looked at those two sigmoid sinuses closely, they actually do look a little bit different. One of them looked a little bit dilated, maybe a little bit closer to the surface of the mastoid bone. And I think it is more, although I obviously can't prove it, I think it's more likely than not that there was dehiscence of bone overlying that right sigmoid sinus on the one where the had the extrinsic tapered stenosis. And so that's something that you wouldn't see with an MRI scan. You would need a CT scan to show that. If you would stent that person, I have no doubt that their pulsatile tinnitus would improve. And you could say, so what's the big deal whether I missed it or not? But it is a big deal because, first of all, it's important to have as much information as possible before undertaking an intervention. And it's important because you may be able to offer the patient a variety of interventions in our practice. And I think this might be someplace where the practice at NYU and the practice at University of Maryland differ somewhat. In our practice, particularly with the current state of things where the stents that are used are really designed for arterial placement rather than venous placement. We don't have unique venous stents yet. If someone's only symptom is pulsatile tinnitus and they have that combination of transverse sinus stenosis and a sigmoid sinus dehiscence, our neurointerventionalists generally prefer that we just resurface the sigmoid sinus rather than putting a stent in. If someone is having other symptoms of elevated intracranial pressure, we take the other approach. We prefer a stent. I'm not saying one is wrong or one is right. There are different approaches, but I think it's important to have as much information as possible so that you can offer each patient as many options as possible and let them be a partner in the decision-making about which approach is best for them.
Yeah, David, thank you so much. No, you're absolutely right. This is actually the CT of this person. So yes, like this is not like this. And again, for the people that are on this chat, like on the webinar, like the message, we were delivering the same message. Like you need people with expertise, the workup. You know, we understand more and more the nuances of the disease here. Like, right. So this question, like we can discuss this because I'm sure a lot of people are wondering. Like what we're talking about is these like dehiscences, like effects of fluid flow on bone, something that's called a diverticulum, which is basically this thing like this. If you look at this as a CAT scan of this temporal bone here, and you see kind of like this sort of like a kind of like a scalloping like this in here, and it's what angiographically on an angiogram on a picture, it looks like this kind of like, you know, this bubble here, which is basically what we're talking about is that bone is living tissue, right? And if there's flow coming, and if there's a jet of flow that hits bone, just like water will drill a hole in the rock, if you give it enough time, water will remodel bone. And so some of these things that we see are, as David, I'm sure knows, like has more expertise. Sometimes it's a combination of like how people's bones are when they develop. Some have like thinner bones over places than others. And then there's combinations of these things. So like all of this needs to be taken into account. Some of the debates we're having in our field is like, do we just like put some coils? Do we just treat this diverticulum, like stuff it with some coils, or do surgical resurfacing? Or do we also put a stent in? So all of these things are like kind of like at the forefront of where we are as a field.
I wanted to ask a couple of questions that we actually received before the webinar that are completely on point to the discussion right now. Could you put up Max, the slides with the arachnoid granulations? The question is about stenting when those are present. What happens to them when the stent is placed? And do you any problems? Have you seen any problems come up? And is there an option to just remove these granulations or not?
Yeah, no. So actually, with intrinsic stenosis, a lot of which is due to intracranial to these granulations. Granulations are generally like fairly soft. They can be like calcified over time, so they can be a little harder sometimes. But generally, they're like squishable, so to speak. So if you put a stent in, the stent needs to have enough what's called radial force, like it has to like push out enough. And when it does that, it'll open, it'll make the stenosis better. In fact, in our experience, that gets into something else that we need to talk about, which is recurrence of intracranial hypertension after stenting. Like when people stenting we are focused on pulsatile tinnitus. So for people that have pulsatile tinnitus as their main symptom, in our experience, stenting has been fantastic. Sound goes away, even if the stenosis is not completely like 100% visually, like in the picture is better, but some improvement usually because of how the flow is, even like if you make it, whatever, half better of what the half that it needs to be, it's usually enough to resolve the sound, and the sound does not come back. With intracranial hypertension, that has to do with other symptoms like papilledema, visual changes, headaches, all these other manifestations. In about 20% of people, the symptoms will come back, and so there'll be a recurrence, right? The symptoms will, at first, after stenting, everything is much better, and then the symptoms come back. Because of narrowing of these, or not because, but it's associated with narrowing of the sinus outside the stent. So the stent opens the sinus, stent is plenty strong. A year later, you take a picture, you see that there's like another narrowing just outside the stent. It again proves that the stenosis is extrinsic. Something else is pushing. It's not like you've taken care of the problem. Now the problem is somewhere else. Some people suffer with this more than others. We are trying to kind of like deal with it by making longer stent, creating like longer stent constructs. And it works, and sometimes just making a longer stent will take care of the problem. Other times you're just like chasing the tail and it narrows outside your longer stent. And we don't understand everything about this disease, which is basically how this goes.
Max, would you consider placing on both sides if you have arachnoid granulations on both transverse?
Yes, I've seen that done. Now, usually, as you know, like the sinus is bigger on one side than the other. Usually, but the right side is bigger. But to answer Emma's question, kind of so digressing to this because all this is important. But to answer Emma's question, with intrinsic stenosis, like when there's granulations there, the results of stenting are fantastic because it's not that something else is pushing on the veins. Like the problem is this intrinsic thing. And if you take care of this intrinsic thing, the problem tends to be solved. So with granulations, I think it works great because the recurrence is less of the intracranial hypertension. It worked great for pulsatile tinnitus. I have seen things stented bilaterally for intracranial hypertension. And sometimes that's enough. Other times it still is a problem. There was a question also in the chat. I think there's an important comment. Anonymous attendee, right? I'm overweight, but I don't have IAH. I lost weight and there's not been a difference in the sound. I hear blood flow. We can't blame everything on weight. I think we addressed this. Absolutely. Like we talk about like, older skinny men that have this problem. So it's not just a problem in weight. And I found that in my experience, weight loss can help with like papilledema, can help with things. Sometimes weight loss does not help with pulsatile tinnitus. Even though it seems to be like whatever, the headaches are better, things are better, but pulsatile tinnitus, it doesn't help so much, which is discouraging.
If I can say something, and I know there are a lot of people watching who are part of the Facebook group. Again, we have over 15,000 members there, and that group has been up and running since 2009. So it's not scientific research by any means, but I think anecdotally, it's probably the biggest collection of people of all types and sex and body weight to provide their experience with pulsatile tinnitus. And I will say that there have been very few people who have lost weight who have reported that their pulsatile tinnitus has gone after losing weight. Hey, is losing weight a good thing for your health overall? Absolutely. Everyone wants to lose weight. And I'll tell you what, if losing weight were the solution to pulsatile tinnitus, we probably wouldn't even be here today, because everyone would be losing weight, because there's certainly an incentive when you have a debilitating symptom rather to fix it any way you can. So I think it's important to note that again, I'm not against anyone trying to lose weight, but usually there's more to it, to the solution of the pulsatile tinnitus.
Emma, may I make 2 points?
Sure.
Regarding weight and IH syndrome. I've been with this business for close to half a century. And there is no question in my mind that when they lose weight, usually the symptoms subside or go away. Now, the patients that they log on to our website and they still have pulsatile tinnitus after losing weight is a selected group of patients. In other words, this information is biased. In other words, somebody who lost weight and lost his pulsatile tinnitus won't have to consult anybody else. You see what I'm saying? But from my experience, and I have seen a good number of IIH patients, weight loss is significant to diminishing or even to have the pulsatile tinnitus subside. We reported a long time ago after bariatric surgery with the late Harvey Sugarman on 16 patients after bariatric surgery. Only 2 of them, they had persistent pulsatile tinnitus. So now there is another possibility. We know by now that although the IIH syndrome has subsided, either because the patient got older or because of diet or whatever, the radiologic findings, in other words, the stenosis in particular of the transverse sinus, persist in some of these patients. The same thing with the empty sella that we see. And perhaps these are the patients that continue to have pulsatile tinnitus after they lost weight. And these are the ideal cases for stenting, I think. In other words, you stent them, there's no extrinsic pressure anymore on the transverse sinuses, and they'll do well.
Okay. Max or David, would you like to comment?
No. I'm aware of this dilemma and debate, and I'm familiar with Dr. Sismanis's data on weight loss, and it's a curious thing because my experience has been a little closer to yours, Emma, or at least the groups, and I guess Max is that. I mean, there are 2 issues with this. If it were just as easy as saying go lose weight, then sure. But it's not such a simple thing, and there are often many challenges with sustained weight loss, as we all know. But even in people who have been able to lose weight, it's been more often than not, in my experience, that their pulsatile tinnitus is still present afterwards. And there are a number of ways that can be explained. There are structural changes, as Max was pointing out, bony changes that once they occur, they won't necessarily resolve, though there are documented cases of sigmoid sinuses reossifying, regaining bone growth after the bone growth has been lost, whether with weight loss or stenting or other situations. But yeah, I mean, I think the bottom line answer to the question that was posed in the chat is, it is not so simple. It is not just, you can't just blame everything on weight. And there are many other factors that will go into causing pulsatile tinnitus in everybody. I mean, everybody's different here.
And David, can I ask you a question, another question that we received before the webinar that I think is specific to your practice as well, is if you have transverse sinus stenosis and diverticulum, do you have to treat both?
So I think the answer to that in one word is no. That in the majority of people treating either one of them will probably, with all the caveats of a complete evaluation and what else is going on and this and that, but I've seen numerous cases on both sides where you treat one and not the other. It's clearly the case that most people who you do a sigmoid sinus wall reconstruction or resurfacing or whatever type of procedure you're doing, most people, their pulsatile tinnitus will get better, and you have not done a thing to touch the transverse sinus. And I think it's also clearly the case in the other direction that most people who get a transverse sinus stent, nothing is being done for their sigmoid sinus wall, despite the fact that there probably is an abnormality there, and they also, in the vast majority of cases, get better. So it's the combination of them. The stenosis is causing the turbulent flow. The loss of bone over the sigmoid sinus is allowing that flow to be, is giving that flow access to the ear in a way that it wouldn't otherwise have. And, you know, if your roommate keeps their light on all night and you can't sleep, you have two options. You could turn the light off or you can close the door. So the same thing here. You could resurface the sigmoid sinus and the sound no longer has access to the ear, or you could stent them and you're getting rid of the underlying cause of the turbulent flow, and that will also solve the problem. Which one of those is the preferred approach, I think is needs to be a question individualized for each patient.
Okay. And I can't remember now who it was that may have alluded to this, but are venous sinus stents approved by the FDA today or not?
I can speak to that. There's no, a lot of this is being done now, and the majority of insurances, Medicare, Medicaid are paying for it. But there's no venous stent. So like devices get approved for a certain indication. I mean, this is like more like nitty-gritty of medicine, but like, for example, a device is approved by the FDA because it was demonstrated to be helpful in some condition, right? Now, once it's approved for that condition, a device can be, it's completely legal, it's totally legit, can be used for other conditions. That happens in our practice, in many fields, and in our practice, not just in pulsatile tinnitus and other things, all the time. So in terms of like, is there a dedicated venous stent approved for this? No. Is that specifically a problem in terms of, it's, you know, like, does that mean, you know, what does that mean for using other stents? It just means they weren't designed for that. They're, in terms of technically, like how to place them, having something dedicated may be better. Hopefully will be. What does it mean for reimbursement and billing and coding? This is a little bit more uncertain because the field is still in development. And so some of these like things that have to do with developing dedicated devices also affects what happens in terms of coverage and reimbursement. But that is still to be, kind of developed.
Okay. There are a couple more questions about transverse sinus stenosis. I know it's a huge discussion in the field now. It is just one possible diagnosis, so I want to broaden things in a little bit just to address our entire community, but there are a couple more questions about transverse sinus stenosis. The next question is, if I have transverse sinus stenosis and mild symptoms of IIH, can I exercise if my symptoms get worse or don't get worse, like weightlifting? I would say, you know, strenuous exercise. Do any of you have an opinion about exercise? Maybe we'll broaden it a little bit, exercise more broadly with the specific diagnosis of transverse sinus stenosis and or IIH.
I'll just make a quick comment, but I'd prefer to let Max address this. I think it's much more in his bailiwick. I don't think there's a problem with exercise, and I think it's probably a good idea to exercise. But this does get to the heart of one of the dilemmas that we frequently see, which is if you have most causes of pulsatile tinnitus, but certainly this one, when you exercise, it will often get worse. And that makes it more challenging to exercise. So one of the things that could potentially help treat your symptom through exercise and weight loss is one of the things that makes it worse. And that is a challenging problem for many people. And one of the things we'll often see from people, hear people say is if I could just exercise, if we thought exercise would help their pulsatile tinnitus, in the long term, they just can't even do it in the short term because it's so disturbing that their noise gets worse. So there's a bit of a vicious circle there. As far as the bottom line of the question, I think it's generally safe to exercise, whether you have transverse stenosis, IAH, or et cetera, but I'd like to hear Dr. Shapiro's thoughts on it also. And Dr. Sismanis. I think they both have experience.
If I may say, at least the patient that I see at my institution, the 48 patients that I reviewed recently, all of them females, their BMI was close to 35. So yes, they should exercise, moderate exercise. Anyway, they cannot, these patients, they cannot jog, they cannot do any aggressive exercise. But part of the weight loss is exercise, no question about it. And most of them, all of them, the pure IIH, they did not have any surgically correctable issues like diverticuli or sigmoid sinus plate dehiscence and things like that. One thing that I always tell my patients is that perhaps your pulsatile tinnitus, and by the way, the pulsatile tinnitus in IIH is not as disturbing as other causes of tinnitus. For example, a patient with an AVF or a dissecting aneurysm. So I tell them that there are other issues that they need to be addressed, and as physicians, we have to take care of them. For example, almost all of them, they have hypertension. Some of them, they don't even know it. Many of them, they are diabetic, et cetera, et cetera. I've seen with cardiac failure. So routinely, I send them to their primary cares and force them to address their other medical issues. And weight reduction is very important. Now, in view of new medications like semaglutide that we see being advertised in the TV every day, I think the management of weight loss becomes a little bit different. Again, it needs supervision, medical supervision, and some other aspects of reducing the weight, including exercise.
I think the question was more about, as a patient, not whether exercise is recommended or not. But for example, if I'm on the treadmill and I feel like my head is going to explode, will it? What are the chances of that happening? And I think, in all seriousness, and Dr. Sismanis, I respect you very much, but there are many, many patients with intracranial hypertension that write to us and write to the group with very with suicidal ideation. I won't code it. It's very it can be very difficult for a pulsatile tinnitus patient, whether they have IAH or no known cause, or, God forbid, a life-threatening one, to deal with the sound and the stress that comes with it. So I guess my question was more about for people that do exercise, who want to exercise, but are worried that they're hearing a sound where it really does sound like your head is going to explode. It's not an over exaggeration, if generally speaking, if that's a concern.
Emma, I'm not a neurologist or neuro-ophthalmologist. Every patient with IIH syndrome should be under the supervision of a neurologist, somebody that will follow them, especially looking at the eye grounds for papilledema. So the reason why their head is about to explode is because they develop a hyperdynamic circulation. In other words, the blood moves faster, flows faster in their blood vessels. And when the speed of the blood circulation increases, that increases the pulsatile tinnitus. Now, I don't think their head will be something serious will happen. But again, it's the neurologist or somebody with expertise in this area. And again, I'm an ear, nose, and throat person, so I would defer this to a neurologist. But again, moderate exercise, I think, is indicated for these people.
So prior to a diagnosis, does anyone have any thoughts about continuing strenuous exercise prior to a diagnosis? Any diagnosis?
Yeah.
Matt?
Look, I think, as Ari said, like, there's a lot of defensive medicine going on. We can't tell for everybody, see a doctor, this and that. But for people with intracranial hypertension, for people with venous causes, like venous stenosis, pulsatile tinnitus, in my experience, I've seen hundreds upon hundreds of these people. No one's head has exploded, thankfully, and I don't think it's very likely at all. It's really venous stenosis is not, when we talk, we gets into these other things, like is it dangerous? Like what's dangerous about it? The danger with intracranial hypertension, the main one is vision loss. Now there are others, like there's all these other things like processing, headaches, brain like problems, depression, all these things. But in terms of like a catastrophe, like a brain bleed is what people are worried about. The answer is that's not what intracranial hypertension is about. I think exercise is good. It's very hard to exercise because the sound gets so much louder, so much like right away. Usually it just gets so loud. It's very hard. It's scary. It's just like it's too much. But is it dangerous in terms of bleeding? In my experience, no. It's hard because it makes it harder to lose weight. So a lot of these things are challenging, but no, it's not. So now the question, Emma's question is, can you exercise if you don't have a diagnosis? That question is a little bit more, is harder because it's hard to know what's going to happen if you don't, like if we don't have a diagnosis, we can't offer a prognosis, right? Like what do we think is likely to happen? Well, we don't know because pulsatile tinnitus is a symptom, not a disease, right? Like a dural fistula, which is rare, but more dangerous, quote unquote, because they can bleed, they can really hurt people. That is a different disease, and not that exercise is not contraindicated in it, but it's a little bit more scary sometimes. But for the vast majority of people, exercise is okay. Gets into the question of pregnancy. What can I get pregnant? We want to talk about like what happens if I get pregnant. I have been pregnant, with this sound, or it developed during pregnancy, and now it's not going away. So that's a whole other thing we can talk about.
Yeah, actually, let's jump into that because I don't want another webinar to go by without answering some of the questions that have come in over the years about pregnancy. If a woman is pregnant, is she and she starts to whoosh, in your experience, in your practices, what should she do? What does one do? What are the limitations to what a pregnant woman can do in terms of getting a workup as opposed to a non-pregnant woman whoosher?
Emma, it's not very uncommon for this to develop in a pregnant woman. And I can tell you in most of them, after delivery, the whooshing goes away. I've seen several that the whooshing persisted after. What happens is, again, they develop intracranial hypertension during pregnancy, and they develop the whooshing. But in my experience, after delivery, within 2 months or so, it's gone.
Okay.
But the prognosis is good.
Dr. Shapiro or Dr. Eisenman?
So it is common to see it develop in pregnancy. I think it is, as Dr. Sismanis was saying, related to a secondary development of elevated intracranial pressure due to all of the mass that's accumulating in the abdomen and constricting the outflow of blood. It's important to recognize here as well, as Dr. Sismanis said before we started the meeting, that there could be other causes. Women in pregnancy often have what's called a hyperdynamic state. Their heart is pumping harder, it's pumping blood faster. They can also, for a variety of reasons, develop anemia, which may cause to pump even faster. And all of those features which can accentuate pulsatile tinnitus or make it present when it was not present, the vast majority of them are going to be reversible after pregnancy.
And what about the woman that was pregnant before? The woman, I'm sorry, I'll start over. The woman, female whoosher, she's whooshing, right? She's not pregnant yet. She'd like to have a family. Are there any reasons why a woman in that situation should, and she doesn't have a diagnosis, should she wait to have a family? What tests, if any, should she have before trying to get pregnant? And what kinds of complications can she suffer if a diagnosis is found during pregnancy? I guess if that would depend on the identified cause, but if any of you could speak to that question, that was another one of the questions that we received.
I can speak to that. So basically, I think that in general, the majority of pulsatile tinnitus is venous, which again means that relatively like benign prognosis in terms of like bleeding and all these other things that people are worried about. So if a woman is not pregnant and develops a sound, she needs an evaluation, right? We need to see, can we come up with some of these diseases? Like if a woman has a dural fistula, it's a good idea to take care of it probably for a lot of them before getting pregnant. If the diagnosis becomes like venous sinus stenosis or one of these venous causes, in my practice, I don't tell people that pregnancy is contraindicated. I think pregnancy, people, yes, pregnancy, I think can be pursued. It's hard to know what will happen during pregnancy. Some of them get better, some of them, the sound, in terms of the sound, some sounds get worse. Of course, there's like people, like there's intra-abdominal pressure, as we mentioned, people put on weight during pregnancy, like naturally and excess a lot of time. So that can make things worse, but it still is like a venous stenosis. So a lot of people I see have gone through pregnancies with the sound, or had a pregnancy, developed the sound, didn't go away, had another pregnancy. The sound can get better, the sound can get worse. If intracranial hypertension, sometimes the question is like, how do I deliver? Do I deliver by C-section or not? That a lot of it has to do with like decision of the OBs, a lot of pressures to do C-sections here in the States, but I don't think it's necessarily has to be that way.
I think a basic workup, a basic evaluation is necessary. At least examination of the eye grounds, an eye examination, make sure there's no papilledema, because if there is papilledema, if there is associated IIH syndrome, and she gets pregnant and the intracranial pressure increases, then the chances of the papilledema worsening exist. And that's the main complication of this syndrome, loss of vision, okay? Otherwise, nothing serious will happen to the patient, but you don't want to lose the vision.
And are there any specific recommendations for the woman that became a whoosher during pregnancy and for whom the whooshing did not go away once she gave birth?
I would get a radiology imaging studies, especially an MRV or CTV to see the dural venous sinuses.
Yeah.
Make sure there's no stenosis, or a plain CT to make sure there's no diverticulum or dehiscence.
I think the bottom line, I think we all three would agree that that situation is one where it's most likely to be a venous venous cause, which is most common anyhow, but that situation specifically is pointing towards a venous cause, and you need to have whatever appropriate evaluation there is for the venous cause of pulsatile tinnitus.
Okay.
I should add that, in general, for a pregnant woman, an MRI without contrast is considered safe. So say somebody develops whooshing during pregnancy. What am I doing? What am I doing? People differ on that. I mean, there's a lot of like opinions, what's safe, what's not safe. Medically speaking, generally, the contrast material, the gadolinium-based contrast, we don't give during pregnancy. Non-contrast MRI non-contrast MRA, non-contrast MRV, the vast majority of us, like doctors, professionals, would consider safe, myself included. So, and that's done a lot of times for other reasons, like something's found with the baby, like, need to have a fetal MR. So that's standard of care for a lot of things. So that one can have. It could give a lot of information. The one thing that's we kind of like alluded to is, even if there's no cause that's identified, and a normal MRA, for example, an MR angiogram, which looks at arteries of the brain, there are some things that can be reassuring, even if we don't really know what's happening. We can reassure the person, look, these MRs don't show anything that we think is going to be, that we think is high risk. So we could kind of proceed with the pregnancy after delivery. A lot of more things we can do to look into it.
Okay, and I will add that there have been various experiences from pregnant women in our group. Some have reported no change to the whooshing. Some have reported, intense changes to the volume and pitch of the whooshing. So it really does kind of run the gamut. We don't have a singular experience with it, but this has all been really helpful.
Emma, it's kind of intimidating for me to speak to you, because however many patients I see with pulsatile tinnitus, you speak to an order of magnitude more. So whatever I say, you're going to turn around and tell me that that's not correct.
Well, no, I mean, it's the group has been really forthcoming. It's a private group. For those maybe joining who don't know about our Facebook group, we have a private Facebook group, which is as private as Facebook gets, where you have to answer a bunch of questions and prove that you're a real person and not a bot. And we have rules in the group and admins that monitor the group just to make sure the discussion stays on point. But we hope that it's a safe place, or as safe as you can be on the internet, to share your experiences with one another. And I think particularly for pregnant women, and I guess this is where I'm not a doctor, but I have had a baby. So I can attest to, the possibility that you can have a healthy pregnancy and come out just fine as a whoosher. I had minimal changes to my whoosh, actually, thankfully, but it was a concern, hey, am I gonna, start whooshing 10 times as loud, with this thing inside of me? What's going to happen? And there are a lot of unknowns with any pregnancy, but when you're a whoosher, you think about that, and especially when you're planning for a family, you think about that. So I think this has been really helpful to get everyone's point of view.
No, I think, and I was being facetious, but these webinars and your Facebook page are an incredible resource. Dr. Sismanis, who has, had one of the longest and busiest practices around, he showed us his data of 250 or 300 patients over the past decade, but you speak to 15,000 patients all the time. And so that's an incredible resource for us and physicians. And it's a pleasure and an honor, really, to be a part of a group that shares this much information and is working together to a shared goal.
Thank you. Yeah, I think it's great. We're going to try and figure out ways to maintain the privacy, of course, of all the members that have joined the group, and how to use, with their permission, of course, information that we have learned over the years, because I agree. It's just, it's also just really helpful as a patient to have, access to other people that are experiencing what you're experiencing. It's really great. There was a mention of contrast, and that kind of is a good segue into some of the other questions that we received about contrast and the, how do you all feel about using contrast in MRs in particular? Is it safe? There's been a lot of articles recently about contrast. So I did want to definitely include a question about contrast. Is it necessary for a whoosher to have contrast with their diagnostic testing?
That is a controversial question. And the answer is it depends. It depends on what diagnostic test is being chosen. Depends how willing you are. Would you prefer to have multiple tests, none of them with contrast, or would you prefer to get things done in one single shot with one test? That may differ depending on what your access is to medical care. If you live, I practice in downtown Baltimore. If you live or work in downtown Baltimore, that's one story. But if you live out in Western Maryland or West Virginia, where it takes you 6 or 8 hours to get to us, you'd probably prefer to have one single test done correctly rather than 3 sequential tests. So it's going to depend on many factors. And this is a hot area of debate. Our practice at University of Maryland is we prefer to do the initial test with one single contrast enhanced CT scan. There are other people who would prefer non-contrast MR-based scans with, you'd need an MRI, you'd need an MRA, you'd need an MRV, which could all be done in one setting, perhaps, all of which with non-contrast, but there are issues of time, there are issues of expense, so it's not a simple question.
Yeah, I mean, I agree. Absolutely. It's in general, like, okay, if you're asking me my opinion, do I think MR contrast is safe? I think it's safe. I mean, other than allergies, like allergic reactions, certainly, and there's definitely an issue with renal failure, like there's syndromes described with kidney failure, but in a healthy person with good kidneys, is it safe? I believe it is. But, there's people that there's a lot of research going into like where it persists and this and that. I would say this, that if a person is concerned for whatever reason, they don't want this stuff in their body. I would say this, that MRIs are just like anything, like cars. Like when you're buying, you don't go to buy a car. You're looking for like something more specific, and you want like a good one, probably. Whatever is the best that you want, money can buy, and you're interested. MRIs range from like 15-year-old machines that like you barely see anything, to modern, 3 Tesla, whatever, like brand spanking good things. If you're not going to use contrast, you have to invest into finding a good MRI machine. Like the non-contrast ones, you probably want a 3 Tesla one. You want one that's like less than 5 years old in a good place. So it'll take a little bit of work where you are. You just ask him, like, how old is your machine? Is it 3 or 1.5? Tesla is the strength of the magnet. So the 3 Tesla is the stronger one, commercial ones. You get way better pictures without contrast than the 1.5s. So that's, I think, is the step to do if you're worried about contrast.
And those machines are usually found in university hospitals mainly, or does it?
Not necessarily. Depends. No, not necessarily. There's some university ones that just don't want to buy a new one because it ain't in their budget for another, 100 years or something like this. And there are some like private ones that are like really top notch. It's research. It's like just doing some background work.
I think the other important point in regard to your question, Emma, which is a point that has been emphasized on your Facebook page and on this webinar over and over and over, there's variability in the MRI, in the CT, there's variability in the machine, there's variability in the person who's reading that MRI scan or CT scan. So one of the answers to your question is, the radiologist has to be honest with themselves about where their strengths are and where their skills are and what they can do best. And maybe the answer is they should be doing the study that they know how to do best and are most confident that they can interpret. But just because you've gotten an MRI, and we see these all the time on this webinar, every one of us gets emails like this all the time. I had an MRI, I had a CT, it was negative, what do I do next? And they send us their images, and it's not negative. It clearly points to a cause of their pulsatile tinnitus. So it's not a generic thing, getting an MRI or getting a CT or getting this or that.
Okay. That sort of leads to a broader topic I want to switch to, which is a more general one of diagnostic testing and different algorithms that perhaps each of you recommend for the new pulsatile tinnitus patient that just started whooshing. Where should they start? Who should they try to see first? if they can. We have, again, people from all over the world as part of our community. And unfortunately for patients, there are limitations depending on where they live to their access of two different specialists. But I wonder if you could each speak to your, again, general recommendations for the pulsatile tinnitus patient that just calls you up and, wants to know how you recommend moving forward in terms of a diagnostic workup.
How about if I start? Basically, Emma, I presented this in my presentation just a few minutes ago. So I think that all of these patients, they need a good ear examination. You have to, somebody who is expert in examining the ears. Is there something behind the tympanic membrane? I mean, somebody has to look for that. Anyway, a good clinical evaluation is the number one and important thing for these patients. You need to take a good history, and you have to perform this clinical examination. Auscultation, is this objective? Is it subjective? That's very important. Is it venous or is it arterial? Now, whoever can do this, that's the person, the medical person that should evaluate these patients. But again, when you have a sound in your ear, a noise in your ear, automatically you go to an ear, nose, and throat doctor. So most of these patients, they have been to an ear, nose, and throat doctor to start with. So clinical evaluation is very important, and based upon that is the imaging studies. If you just get x-rays, imaging studies without the clinical evaluation, you get what I presented, about 50% undiagnosed cases, that high. So, and oftentimes we don't have the time in the clinic to spend with the patient. I can tell you that I need about 45 minutes to evaluate a pulsatile tinnitus when they first come to the clinic. So if you have 15 minutes allotted for each patient to see, it's not easy. So some of us send the patient directly for imaging study, get an X-ray, a CT, an MRI. How about if the patient has anemia? Nothing is going to show in that study. How about if the patient has migraine? Nothing is going to show in that study. How about if the patient has a heart murmur that radiates to the ear? If you don't put your stethoscope on the heart, nothing will show on an imaging study. So clinical evaluation, and then imaging studies and other tests like blood tests, etc.
Great, thank you. Dr. Eisenman or Dr. Shapiro?
I was hoping you would overlook me, but I think Dr. Sismanis' answer is clearly correct. The problem with this question is there is no one correct answer. You have to know where you are, who is the person who's most likely going to be able to help you, and that's going to differ depending on where you are. If you're on, 26th Street on the east side in Manhattan, so it's very obvious who the person who's most likely going to be able to help you is. But when you don't have access to all the best healthcare in the world, was it 34th Street? I don't remember NYU, but even if they're that far south as 26th Street, they're still going to come up to you, Max. But you don't have access to everyone if you're in a more rural setting, or you don't have access to all the top doctors in the world. That's a challenging question. But I think intuitively, Ari's approach is correct. Probably the first person you want to see is going to be an ear, nose, and throat doctor. That does not mean they are going to get the answer correctly, but by no stretch doesn't mean that. But I think that's where you have to start.
And that's maybe where our top 10 tips and the informational file that we pointed to earlier may come in handy if your ENT may not be as familiar with pulsatile tinnitus as with tinnitus, that you could respectfully show them those files and at least get their attention. Yeah. I know another question that we had from our community, and this is a widespread issue. Why is it that when a patient comes in with something they found from the internet, why is it that most of the time their doctors will not pay attention to what they've brought in? And is there a way or a, I don't know, recommended manner of communicating that, there seems to be information that the doctor may not know. Here's some information written again by doctors. Here are links to medical reports and such that are all available and published online. How can a patient best advocate for themselves? Perhaps they're not in an area like New York or another big city where there are doctors we know who are very familiar with this symptom. If someone is in an area where no one they know is familiar with pulsatile tinnitus, what can they do to best advocate for a proper attention at first and a proper workup?
Okay, I can say something to that. I think, look, as you can see, like we physicians are like way far from perfect. There's a lot we don't understand. Even, in not just pulsatile tinnitus, if somebody has a rare disease of whatever it is, like they find themselves in a place where people don't have expertise in that particular disease, it's very challenging. Like their child has some syndrome, and the closest place is, I don't know, Mayo Clinic or someplace like this, or Boston or New York. It's so hard. And this is part of it. So I think part of it is just, yes, like it has, like a lot of it just has to be like research, advocacy, looking for the right people. I would say in general, like you have to decide, like, what do you want from the local doctor that you're seeing? If you're trying to get an MRI ordered, so that you could get started, I think you can convince them to order an MRI, MRV, whatever, was the 10 tips or something. I think that's reasonable. Certainly if they don't know, but if they don't know the disease, you probably don't want them taking care of you for this. Like you want to find somebody who does. What can I say that's positive about it is that, virtual visits, because of, catalyzed by the pandemic, are much more common now. Like your insurance is obviously it's a whole other thing, but a lot of insurances now allow for virtual visits. So you do have more options. And a person who knows, my opinion is, somebody who knows about this disease who is far away is better than somebody who doesn't know about it who is close. You get your scans, whatever you can get, make sure you get those CDs, or, have some way of sharing the scans. There are many more ways now. Used to be just sending CDs. Now you could, like, there are portals, radiology portals you can share, this and that. And you start, Emma says about this all the time, circulate your scans. See the people, circulate your scans. I think that's the way to go.
And it's important to circulate the images themselves, right? Not just the reports that.
Sure. Reports are meaningless.
Right.
Most of the time if they're negative. If they're positive, it's a different story. But if the report is negative, is it really negative?
Okay. And what can a patient actually say to the first doctor that they see? We know there isn't a whole lot of, it's growing, but there isn't a whole lot of education about pulsatile tinnitus. So saying I have pulsatile tinnitus doesn't necessarily work and get the right level of attention. So how would you all recommend that a patient describe the sound to their doctor?
I say, tell them I have a bruit. I hear it's not a problem with my ear. I have a bruit. I hear blood flow in my ear. I think there's some sort of could it be that I have just like a carotid, like a bruit that every doctor is familiar with, like a bruit, which is an abnormal sound of some blood flow in their heart, like Ari was saying, or in the neck or wherever. So I'm hearing a loud bruit. Get people thinking in that direction. You have to get away from, people, a lot of times people think in these concepts, I have a concept of tinnitus, an idea of tinnitus. Get away from there, get to the idea of some blood flow problem. Take it from there.
I hear my heart in my ear, probably.
I would try to stay away from the word. I think that's what everyone agrees. Stay away from the word tinnitus or tinnitus. All right, you should just be describing your symptoms to the physician. or clinician, whomever it is that you're seeing. Describe the symptoms. And yeah, there are words, I think saying bruit or hearing my heartbeat, it's a good idea. It'll trigger a certain path of thought from the person listening to you. As to your original question, Emma, I mean, I can honestly say I have no idea why a clinician would not want to listen to the concerns that the patient has as to what might be causing their symptoms. If someone comes to me with something from the internet saying, is this what could be causing my problem? Of course, I'm going to want to listen to that. Whether they're right or wrong, a physician is thinking, well, some physicians, well, I've went to medical school for this long, a residency for this long, a fellowship for this long, and you think you're going to find the answer by, going on Google. That's obviously the reason why they may be somewhat skeptical. But if you view your role as a physician as helping, minimally alleviate somebody's concerns about what problems they might be affected by, then of course you should want to listen to what their concerns are and confirm or help them, convince them that that's not what's going on.
So if a patient experiences that, just that with a visit to a doctor, which by the way, in some areas of the world, they wait an awful long time for the initial consult. And, they leave after a 2.5 minute consultation. What should they do? Should they try to go back? Should they try to find someone else? Should they go, equipped with not just the 2 foundation files that we alluded to, but to, medical reports? Should they keep a binder of medical reports in case that happens? What can they do?
Emma, I think they can do anything of what you said, but most important, to find a physician who is sympathetic to their symptom. If he does not know himself or herself what is going on, at least to look around, advocating for the patient and see what he or she can do about the patient. I think that's very important. If he does not know about it, I bet he knows somebody else with who is more knowledgeable about medicine or whatever, the closest major medical center, to find somebody who can help the individual. But you need somebody who likes to take care of the patient.
That seems logical, and you'd think that all doctors go into their field with that motivation, but we've seen, when perhaps they're faced with something new and may not want to be educated for whatever reason, we have been encouraging fellow patients to find another doctor, because you wouldn't want to take the advice of someone that doesn't know anything about pulsatile tinnitus anyway, that they might be doing you a favor, actually. I mean, looking at the bright side, right? That maybe that's just a red flag, sooner rather than later to find someone that can help. One of you mentioned subjective versus objective pulsatile tinnitus. I wonder if one of you can briefly describe the difference between the two, and perhaps any particular findings that are more prevalent with one or the other.
About subjective is only when the patient, he or herself, can hear the pulsatile tinnitus. Objective is when both patient and the examiner can hear the pulsatile tinnitus. Now, again, if you try to auscultate, to listen to somebody in a regular examination room, the chances are you won't be able to hear it with a regular stethoscope. Years ago, I took 10 patients with objective pulsatile tinnitus. In other words, I knew that they had objective tinnitus, and I examined them in the regular examination room. We measured the ambient noise, I think was around 45 decibel, 40 decibel. And then we took them in an audio booth in a quiet area using electronic stethoscope. Guess what? Only 3 patients in the regular examination room, we were able to detect the objective tinnitus. So does it make any difference? Well, in some cases it does. If you have a loud objective bruit behind the ear that is arterial, in other words, you put pressure in the neck, it does not go away, that's very, very suspicious of being an AVF at your venous malformation, something which is similar, something that can be serious and can be associated with a stroke. These are the patients that you have to be very, very alert and suspicious for this particular lesion. And often I will get an angiogram in these cases if the CTA is not revealing. Although most of the CTAs I have seen recently, they will pick up an AVF. So a loud bruit around the ear that does not go away with pressure in the neck is something suspicious or something very sinister. Most of the venous cases, like in intracranial hypertension, you may not be able to hear the pulsatile tinnitus. In other words, it's subjective.
That is the definition. It's not that helpful, though, clinically. If you can hear it, then if someone else can hear it, meaning it's so-called objective, then that is going to make you more diligent about looking for a cause, I suppose, or more optimistic that you'll be able to find a cause. But if you can't hear it, you should still really be equally optimistic. So from a clinical perspective, there's some value to it, but from a diagnostic code, from my perspective, they're both pulsatile tinnitus still.
And they both warrant a full workup. So if you have objective, of course, it maybe is more alarming to the physician because it's alarming to hear the sound. But if someone has subjective pulsatile tinnitus, in other words, that the patient can hear, it doesn't make it any less concerning, and they should still have a full workup.
Absolutely.
Totally. I think I see like over time, we're getting away from this subjective objective business. Because it used to be, honestly, it's more for doctors, like to convince a doctor that this is real or not real. Well, maybe your stethoscope is not good enough. Your room is not like quiet enough, right? So a lot of it, I think, is not, well, it's not.
If I may add something, Max, it's important to some patients because some patients may think that they go crazy. And the moment you are able to detect it yourself, I've seen so many of them going out, getting the spouse inside. Listen, he was able, to hear it. I put it to the husband's ear, the stethoscope, he can hear it there. So it's reassuring to the patient that they're not going bananas, that there is something there that somebody else has identified, having been probably in another 2 or 3 other physician offices. So from that point of view, I find it useful to be able to detect it.
Oh, for sure.
Thank you, Ari. Yeah, totally. No, you're absolutely, definitely.
You should certainly listen, and it's very reassuring to them. I don't use it in terms of my diagnostic code. I don't code it as objective pulsatile tinnitus or subjective.
No, I don't either, no.
Code it as pulsatile tinnitus. As far as listening, what I do is I use a digital stethoscope that can be frequency specific and can amplify, and I hook it into noise cancellation headphones. That's what I use for listening to everybody. I use a noise cancellation headphone with a digital stethoscope that has frequency specificity, so I can listen for low frequencies, high frequencies, and I can amplify it and eliminate ambient noise.
I agree. I think, again, as a patient, finding a sound, whether you're able to record your own or we do have a sounds page on our Whooshers website that we've collected over the years. There are actual whooshing sounds that people with objective pulsatile tinnitus have recorded and sent in to us, and we've posted them there. There are, of course, a lot of people that have subjective pulsatile tinnitus or objective pulsatile tinnitus, and I am one of these people, so I know it's possible to have objective pulsatile tinnitus that cannot be recorded. It really depends on where the original, where the origin of the sound is in your head. So I, when I'm bored, sometimes I take my iPhone recorder and try to still, after all these years, still try to record it, but it's not able to be recorded. But if someone standing beside me puts their head up next to mine, they can hear it. So it's interesting. But we have a lot of audio files on the Whooshers website. I encourage anyone, especially those of you new to this, to visit that page and find an audio file that sounds like yours, and then you can, save the clip on your phone and take it with you to the doctor or play it for your family and friends. I agree with Dr. Sismanis that brings so much relief when you can play it, maybe not for the family and friends, but to have others just kind of nod like, wow, that's what you hear? That's crazy. And it is, it's a really crazy thing, this pulsatile tinnitus. So definitely check out the sounds page. It's probably the most frequently viewed page on the whole Wusher site, by the way. Let's see. Are there any, we've got about 8 minutes left. Maybe I'll throw those 8 minutes to our respective panelists and see if there are any closing remarks or topics they'd like to cover, or questions that have come in on the chat, if any are unanswered. I know we have a lot of questions that came in that we didn't cover, so I could keep asking questions, but.
Well, if I may ask a question, my colleagues here, let's say you have a pulsatile tinnitus on the right side, and there is a stenosis of the transverse sinus on the left side. Could that be the cause of the pulsatile tinnitus?
So we have seen a number of people like that. Some of them have been published. The ones that I've seen are people who have had, let's say, or two variations on it. The sigmoid sinus dehiscence on the right side, which is the dominant side, and a hypoplastic or stenotic transverse sinus on the other side. And presumably it's the increased flow going to the right side that somehow or another led to the whole event, whatever theories you espouse to. So we have seen that.
Always with a bony dehiscence, David?
The ones that I have seen have been associated with that. I don't recall seeing one without that. And most of those we have been successful in treating. I just had one patient last week, unfortunately, who had that combination. The dehiscences that she had were not typical, though, and I told her straight out I wasn't convinced this was what was causing her symptoms, but there was sort of no way of moving forward without first trying to address that. And her surgery was not successful in eliminating it, eliminating her sound. Her dehiscence was low down, just to use medical talk for the panelists, even not everyone understands it, just proximal to her jugular bulb in that little siphon as the sigmoid sinus goes back up, ascends to the jugular bulb. It was very at the end of the sigmoid sinus, rather in the beginning of the sigmoid sinus where dehiscences usually are. She had small dehiscences up at the top that were very, very small and subtle. And our treatment for it was not helpful. Whether or not, I don't think you would be able to stent her hypoplastic left transverse sinus. I don't think that's a stentable phenomenon, and it's not from extraluminal compression. We're going to continue to look for what may have been causing her, but I have seen that combination be successfully treated.
Thank you. Thank you.
Great. Dr. Shapiro, any last thoughts?
I think I hope it's been helpful to everyone. I think we touched on a lot of things. And we're concentrating on venous causes because those are the most important, numbers-wise, most common. But there are many others. I think we already alluded to them in the beginning. There are other things.
Can I ask a question, Max? Can you tell the difference? I mean, the difference between a hypoplastic sigmoid sinus or transverse sinus and a stenotic one? Is there such? I
think so. I think in most cases, like for transverse sinus, the vast majority of them I think are hypoplastic. In my experience, developmentally, so one is like, so I don't know, in my experience, the intracranial hypertension, like all of these stenoses are usually bilateral.
And distal, right?
And so like distal, like transverse sigmoid junction, sometimes it's transverse, but they're usually bilateral. So I think there are like secondary signs. You could be pretty sure in the end what you're dealing with. And yeah, like I said, there's so many like variations. There's a lot we don't understand about veins, like for people that are on this panel, like more medical stuff, but there's a lot of like, there are things we didn't even talk about that are so important. Like for example, Everybody knows this jugular vein. It's probably like the biggest vein, takes care of a lot of blood outflow in the brain. Now, the funny thing is, there are many other ways that blood leaves the head. You know, there's like cavernous sinuses here, like veins in the back of the neck, other stuff. It turns out, very consistent, our results, other people, when we lay down, the jugular participates in a lot of the drainage of the brain. When we sit up or stand up, you would think this big jugular is going to do even more. No, it does less. Like veins in the back of the neck are taking out more blood flow. The jugular becomes more narrow. Like a lot of these things are known to the people that are dealing with veins, but how that works, like, you know, what role it has to play, like a lot of these things are still like we need to understand. We don't understand how pressure varies in the veins with different head positions because it's harder to measure them in these different situations. Most of people are like laying down for their angiogram, really flat. Like we don't even sleep this flat. You don't even get a pillow really. You're just like totally flat, which is not very physiologic. So I think we've made a lot of stride. Like there's a lot that we understand. There's a lot.
Do you measure the transverse sinus when you review MRVs and things like
I
that?
measure pressure. So pressure measurements, I think, is very important. We didn't talk about it so much. Like measuring the pressure gradient is important. Like, does it mean that you can't stand someone who doesn't have pressure? No, like, but it's a different parameter that is not measurable with MR, for example. So it's a totally different thing that we're collecting.
And the size, you don't measure the size of the
Size we do, but because it's not totally round, like there's like different ways of like how do you estimate the right size stent for this thing? You know, do you just like average some couple of measurements and this and that? That's all like in development. But in general, like the thing about stents for veins is it's important not to oversize them too much. For arteries, okay, you have a 6 millimeter artery, put an 8 millimeter stent in there, maybe. It'll be
Is
okay.
MRV better than CTV to determine the size?
In our experience, like we're blessed, NYU, you know, have good machines. We have very like high-end 3 Tesla machines. So at 3 Tesla contrast MRV is the best in our place. CTV is okay too, but most people, a lot of places don't know how to get a good CTV. They know how to get a good CTA, and if it's late, you happen to have a CTV. But yeah, I think MR is actually quite good at this, and sometimes angio is not even as good because you're not like directly, unless you get a venogram.
Well, thank you. I learned so much, and I'll tell you.
There's other things like we do, like places that like ourselves, a couple of other places I know. Like there are things that you could do now for patients that have these noises, right? We do a lot of like provocative testing, meaning they're on the angio suite, laying flat. If they can hear their sound, we can either inflate a balloon there temporarily or like one of these like weird stent-like devices that you don't have to put in permanently, to see what changes in their sound can be elicited if they can hear their sound in the angio suite, which is a bit noisy, but with some earplugs sometimes works. So like there's this stuff that can be done now by, you know, but so sometimes that's very helpful.
I would just make 2 points, Emma. This is a great discussion. There could be a difference between what's the best test for quantifying, you know, systematically, meticulously quantifying a degree of stenosis or measuring this or that, as opposed to the best test for trying to figure out what was causing something to begin with, right? When you have the patient who's the tabula rasa, you don't know what's going on. What's the best test? That's a different question than I know what's going on. What's the best test now to accurately quantify exactly the degree or this or that? Those are 2 separate questions. I would also say, and I'll say it by way of a quick anecdote, because I worked in a private practice in ENT for a while, and I've worked in academic medicine. And when academics try to study a completely unrelated phenomenon called sudden sensorineural hearing loss, it's something that ENTs all see not uncommonly. It's very hard to do studies on that because in academic medicine, it seems like it's a very rare phenomenon. When you work in a private practice in ENT, you learn that it's not at all a rare phenomenon. It's actually quite a common phenomenon, but the vast majority of people get better with initial treatment, and they never make it to the academic centers. So when you look at academic centers looking at what are causes of pulsatile tinnitus, their list of differential diagnosis is going to differ from others. And it's not even just an academic or a private practice type of thing. For myself, for example, if someone comes into me with pulsatile tinnitus and I look in their ear and I see a small paraganglioma, a small glomus tumor, when I code them at the end of that visit, my diagnostic code is glomus tumor. I don't always put in the symptom that they had of pulsatile tinnitus. So if you go back and look at my charts, you're going to think glomus tumors are an uncommon cause of pulsatile tinnitus, but it's not the case. So when you're talking about what are common causes of pulsatile tinnitus, often, and you have to be aware of this when you read the literature, often the question is not what are the common causes of pulsatile tinnitus, the question is what are the most common causes of pulsatile tinnitus when you don't see anything on the hearing test or looking in their ear or something like that. That's a different subgroup of people than the question of what's the most common cause. If you would look at the most common causes in a general ENT practice, I think you'd find quite a few more glomus tumors than you will in an academic practice.
Yeah, we have a lot, well, not a lot, but we do have some glomus tumor medical reports linked on the Wooshers page. And for those of you also may not be familiar, the Cured Wooshers page on the wooshers.com website is where we've been linking to medical reports and personal stories, but mostly medical reports for so many different possible underlying causes. So I know we've only just poked at the surface today with discussion about a handful of them, but there really are, for better or worse, there are many possible causes of pulsatile tinnitus. So I encourage you all to visit the wooshers.com website and the Cured Wooshers page for more information. Speaking of which, we're out of time, but we are looking at revamping the wooshers.com page, which, as many have pointed out, is not mobile friendly or even eye friendly anymore. There's so much content there. It was never intended to be or contain as much content as it does, and I'm glad it does. But we need that to be reformatted and redone. So we again, the Pulsatile Tinnitus Foundation is managing that website, and we are looking at redoing it and working on that. So we could really use any contributions from our community to help us with that, along with other initiatives. Again, all of our panelists today volunteered their time. We don't do this for the money, but we'd like to do more in terms of reaping benefits from grants and that kind of thing, to really get some good work done. And so any contributions that anyone can make to our foundation would be really appreciated, sincerely. So I want to thank each of our panelists. Thank you, Dr. Sismanis, Dr. Shapiro, Dr. Eisenman, so much for your time today. We did get through quite a bit of questions. I know we didn't get to every single one, but we'll do this again. If any of you have any of you watching have any questions for our panelists, you can email info@pulsatiletinnitus.com. That is our main email for the foundation, and I'll be happy, or one of us will be happy to forward your question for any specific doctor to the right place. And with that, we'll do this again soon. It won't be another full year before we do, and we'll post more information as we develop it. So thank you all for your time, and hope this has been helpful.
Thank you, Emma. Excellent moderation.
Thank you. Thank you.
Terrific discussion. Thank
Have
you.
a great weekend. Bye-bye.
Bye-bye. Bye-bye, everybody.